Hi, good morning, everyone, and welcome to the GAP MASLD MASH Community Network. My name is Whitney Steinmetz. I'm a nurse practitioner. I practice out of Albuquerque, New Mexico for Presbyterian Medical Group. I have been a nurse practitioner in GI and hepatology for a very long time, and I'm really happy to be here today. So remember to register for the meeting, especially for CME credit. That's a really important component of it, so make sure you register. So let's get into it. As everyone knows, because we've been talking about this for a few years now, the nomenclature has changed around these disease processes. So just a quick reminder that metabolic associated steatotic liver disease and metabolic dysfunction associated steatohepatitis and alcohol associated liver disease is what we're going to be talking about today. So let's get into a case study. I think this is a really nice way to kind of bring in all the information that we're going to talk about today. So we have Ashley. She's a 52-year-old woman that's come to us after having received an ultrasound showing mild hepatomegaly and increased hepatic echogenicity consistent with steatosis. And she feels well without complaints. I would say that's pretty common that patients are asymptomatic. Sometimes you'll have patients talk about fatigue. That can be a pretty common symptom as well. What's interesting is this is a pretty common patient scenario. And also, I would tell you the other scenario that I see a lot is patients that have had elevated liver enzymes and they're seeing you because of that, and you're getting the ultrasound. So this patient's coming with you for the ultrasound, which I'm assuming was done because her liver enzymes were elevated, and really important to look into the actual report of the ultrasound because a lot of times the steatosis doesn't always get called out on the impression. So let's look through her medical history here. So she has PCOS, hypertension, hyperlipidemia. So we know she has metabolic syndrome. She's drinking 2 glasses of wine per day on average. I think it'd be really important to dive in about what average means for this patient. Is she binge drinking more on the weekends? What does an average mean? And I really wouldn't make a lot of assumptions about what's in the chart. I really ask people, what is your relationship with alcohol? What kind of alcohol are you drinking? And tell me what a typical day looks like. Physical exam, pretty unremarkable usually in this patient population, but don't let that knowledge dissuade you from doing physical exam. I've heard people say recently like the physical exam is dying, and that makes me kind of sad because I think it's really important because you can catch things, and especially in liver patients, and especially on the skin manifestations like spider angiomatas, and that can really lead you down being more concerned about advanced liver disease. So looking through her medications, she's on amlodipine, atorvastatin, a multivitamin, and milk thistle. Whenever I see patients call out herbal supplements on their medication list, I'm really, my ears kind of perk up and I think more about, okay, what are they taking any other herbal supplements? And I really I question all my patients, but you especially want to get into that with patients who are already telling you that they have a relationship with herbal supplements because you want to be worried about an overlapping drug-induced liver injury. So let's look at her vital signs. So her heart rate is 76, nothing, too crazy. Her BMI tells us that she's overweight. Her AST and ALT are elevated. And a lot of times with patients who are drinking to a degree that's unhealthy, you'll see this 2-to-1 ALT-AST ratio or AST-ALT ratio. That can really tip you off to something even in a patient who might not be disclosing alcohol use. So let that be a sign. Her platelets are 210, which is reassuring. Her hemoglobin A1C is 5.9%. What was interesting, and we were talking about her medical history, is I didn't see pre-diabetes there, but certainly she does have pre-diabetes. I didn't see metformin or anything else on her medication list, so I would definitely say something to her about that and talk to her about that, because don't always assume that someone's told them that or had time to talk to them about that yet. She might have an upcoming primary appointment, but I would definitely address that. It's well within the GI purview to do that, especially when we know our metabolic syndrome could be driving the hepatic steatosis we're seeing on imaging and her liver enzyme elevation. Triglycerides are elevated, and we'll talk a little bit more later in the presentation about how that can be another tipping point that someone might have an unhealthy relationship with alcohol. So she has a fibrosis assessment. Likely this is something you're going to be ordering in this visit and then following up with the patient about. So we see her KPA is elevated, her CAP scores are elevated, showing us that she's got significant fibrosis of F3, and her CAP scores are elevated, showing moderate steatosis. So really important to be asking the clinical question of why does this patient have steatosis, and is that steatosis causing fibrosis? And if it's causing fibrosis, what stage of fibrosis are we talking about? Because it makes an absolutely huge impact to the patient, especially her. So now her having F3 fibrosis means that we're screening her like she's a cirrhosis patient. So she needs to start having hepatocellular carcinoma screening, vaccinations, super, super important. And now we have this clinical goal of keeping her in place here, or ideally reversing, right? But the big goal is we have this opportunity here to not allow her to progress even further. So let's just kind of take a break from the case study and think more about steatotic liver disease as a whole. So you see a patient that has hepatic steatosis, and what could be the causes here? And this is why we do serologic workups, right? So this is, whether they have liver enzyme elevation or not, the question is, why is this happening? And this is the clinical question that we need to be asking ourselves. So to the left, we see, metabolic associated liver disease and MASH. And the center here is really discussing what the overlap is. So when do we start worrying about alcohol-related liver disease being more predominant versus MASLD being more predominant? And there's so many patients that are right in the middle there. We know that both of these disease processes are negatively contributing to advancement of their liver disease, right? So really important to think about those weekly intakes of alcohol. On some slides coming up, we're going to talk a little bit more about what that means and what the equivalences of alcohol are. But we have a weekly intake for women ranging from 140 to 350, and for men, it's 210 to 420. And then we have other disease states that we also know that can cause steatosis, right? So like prolonged drug-induced liver injuries, Wilson's disease, extrahepatic things like celiac disease as well. So these are the reasons why we do those workups. So like I mentioned, really important to talk with patients more about what they're drinking and what it looks like. And important for us to know too. It's important as the provider that we know, okay, what is the amounts for which these numbers are coming from? And because that's what defines the disease or helps start a conversation. I'll tell you many times, just having the conversation around how much someone's actually drinking, even without getting into the discussion around how we can make some changes, can be really highlighting for a patient, or just, surprising to them when we talk about this is the definition for a glass of wine. And a lot of patients are like, oh, wow, I didn't realize that the amount I'm drinking, is actually the equivalent of 3 drinks, when I kind of just thought it was 1 glass of wine. And I think some of that is, willful ignorance, and some of it is absolutely people just don't know what these definitions mean. So I think just this alone can be the start of a really meaningful conversation. So let's talk about the mechanisms when we're talking about dual etiology disease or concomitant disease. So we know there's risk factors for MAFDL. So we know insulin resistance and diabetes are really big. Having increased abdominal adiposity, an unhealthy diet, especially ultra high processed foods, a sedentary lifestyle. There's certainly a significant amount of the population have genetic susceptibility, even when they don't have these other issues with obesity and et cetera. And we know alcohol intake also plays a negative role in disrupting the intestinal microbiome and causing all this inflammatory upregulation and progressing fibrosis. And so why this is really important, and one of the analogies I'll use with patients is, it's like you have a smoldering kind of brush fire, and alcohol is the accelerant. That's the match. That's the match you're flicking on, and it just causes an explosion. And I think anytime we have 2 issues going on in an organ at the same time, you're going to see this kind of rapid progression of disease, especially, in my practice when I see, 20 and 30-year-olds with really, really advanced disease, even in those who on objective testing don't have, excessive alcohol use, it certainly explains, even that moderate alcohol use will explain why their disease has progressed so significantly. And I think that really helps the conversation. It's part of the driver of the disease and something that we should be addressing. So on this slide, it really is summarizing how the different drivers interact across the spectrum of steatotic liver disease. So fibrosis stage is shown corresponding with a 5-year risk of decompensation, with earlier stage disease having a less short-term risk, but advanced stages with much higher risk. And again, I think, if you're hearing that and thinking like, well, yeah, obviously, that's pretty obvious. What I think is the important thing to take away from here is, again, when you have multiple things happening at the same time, you're going to watch their disease just progress in a really significant way. And we have the opportunity to do something about that. So I think we should be addressing that in our GI practice. Don't fragment their care by, pushing it to somebody else. Let's start addressing it in these visits in our discussions with our patients. So how do we, detect alcohol use? I think there's so many different things we can do that, or ways we can do that. And we're going to talk a little bit more about that on this slide. So we know there's a variety of factors that contribute to the development of steatosis. We've talked about that. And there's a variety of methods that we can use to screen for alcohol use to kind of help characterize all the factors that are contributing to their disease. So I think the more screening tools you use, the better. I know so many practices, including mine, are embedded with this ability to do screening tests with our medical assistants and nursing staff already. A lot of patients are already getting depression screenings, regardless of the reason why they're coming in to your practice. I think this is a really easy thing to incorporate really for any visit, but especially in any patient who's coming to you for any kind of liver related issue, because we know the prevalence is so high. And I think the more screening tests we do, the better. And it just helps that conversation. As far as that HETG acronym, that's a hair ethyl glucuronide. I have to say I've not personally ever ordered that. I don't think that's being done routinely, but for those of you who are using that, that's certainly an option, but lots of other options available here. And I have patients ask me, or I have people in the community ask me, whether I tell people I'm going to order these tests. Like if I tell the patient, like I'm going to order, objective sampling of ethanol use. And I definitely do. And I don't do it I do it in a wide open way so that it gives them an opportunity. It's not to dismiss anything they've told me. I tell them it's a screening test. It's a really helpful tool to let us kind of see where we can make some changes and adjustments. So my recommendations is I wouldn't spring that on people, because especially with people having such ready access to their medical record, they're going to get these results, often they're seeing them before you do. And you don't want that to tarnish the therapeutic relationship between the two of you. So I definitely say it in addition to all the other tests I'm going to be ordering. So I think, the thing to highlight here is just how many patients with underlying metabolic associated liver disease also have moderate to excessive alcohol use. These are such high numbers. I mean, we screen for a lot less all the time, right? Like we're doing screening tests in which you don't have 25% of the patients that are going to have a screening test be positive. So think about what a big number that is and why it makes sense really just to be screening everyone. So I think, thinking about where are the gaps happening, I think we all can think about what does our own practice look like personally? What's the culture in our practice? Like, when you look back at your whole group, where could we be doing better? So we're going to talk a little bit more about how isolated hypertension and hypertriglyceridemia can be tipping off that someone has an unhealthy relationship with alcohol. We're going to talk about that a little bit later about why that happens, but certainly something to tip you off. And then using a phosphatidyl ethanol. So, phosphatidyl ethanol is a phospholipid that's formed in the red blood cell membrane when it's exposed to alcohol. So it's a direct biomarker of alcohol, meaning that it is not present if someone's not drinking alcohol. So if it's there, it means that alcohol has been consumed. And it also allows us to look at levels within the last 2 to 4 weeks. So what has their alcohol consumption look like over a much longer period of time rather than, other tests like ethanol are much more shorter acting. So definitely use that. I use that that's my primary test. Sometimes I'll use a urine glyconoride when I'm in the hospital screening patients, but I also will always do a phosphatidylethanol. It takes a while at my institution for it to come back. It can take up to 5 to 7 days in the inpatient setting to come back. So it takes some time, but it's still absolutely worth doing. So we do a phosphatidylethanol on our patient, and it's 120, which correlates to moderate to heavy alcohol consumption. And again, going back to what do you do once you get that result? Well, one of the good things about patients seeing the results in their chart now is they see these ranges. They see what it, and on our call out at our institution, our phosphatidylethanol, it gives them exactly what it means. It'll just what you see on the range here on this slide is exactly what it shows at our institution. So I think what can be helpful about that for some patients is it allows them to kind of take in that information and absorb that before you have a conversation. And you really have to kind of feel out the patient that you're dealing with. If you have a patient who is having a hard time understanding that, or it might feel like it can be kind of a surprise to them, or you're worried that there might be some sort of a confrontation. The way that I'll start this off is by saying, this is your number. This is what it means. What do you think about that? What are your thoughts about that? And let them talk to you about what these numbers mean to you. I think so many times it's kind of like a motivational interviewing type of thing. So I think it also takes that pressure off, because the last thing you ever want to do is to make anyone feel judged, because there's absolutely no reason. There's no place for judgment here. There's no reason to judge somebody. It's just, what can we do to make this better? What can we do to improve your health? And let's do it together in a way that feels good to everyone involved, which is why I think this test is super helpful, rather than, only relying on what people tell us. But even when they tell us, that objective number, very powerful. So we talked about this a little bit more about what a phosphatidylethanol is and how it's detectable for a really long time. And there's no significant variability among sex and BMI, which is really great. So it's super accurate test. You don't have to worry about how to interpret it based on your patient. Just really objective, easy to do test. Transplant centers, almost every transplant center I've ever interacted with requires this, and they use this tool. This is really like the kind of the standard tool. So absolutely would use this if it's available to you. And if it's not, certainly might be worth trying to advocate for getting this sort of test part of your institutional culture. So in patients with excess weight and alcohol use, so your local rates may be higher. I'll tell you that. Like, I looked through this study when I was preparing for this presentation, and honestly, I was thinking to myself, I think I'm seeing this a lot more often, for sure, in my state and in my local practice. But I think what it comes down to is a lot of patients have a relationship with alcohol that is creating a lot of opportunity for improvement and is certainly affecting their health negative. So if you're not doing this, I can't emphasize it enough. Keep screening these patients. Yeah, so there's that number. That's the number where I thought it's still so high, but I would say in my practice, 30 to 40% it would be a conservative estimate of how many patients I'm having a conversation about how we can do better, for sure. So let's go back to our patient information and talk a little bit about, what can we do, what could we do better here? That's kind of the way I approach, like, how could we improve her care? What can we add to the list here? I would certainly start adding some things to the chart. I think we dump way too much on primary care. I think we dump way too much on patients. I think, like I said, if we know that these are the disease processes that are contributing to their liver disease, let's make it better. So I would have certainly put prediabetes on her list here. I would put that she's overweight and put her BMI. I would say she's got, a moderate alcohol use. Whether you want to call that a disorder or not, you have to dive into the definitions of that, which is a good conversation for another talk. But I would certainly say moderate alcohol use and part of her medical history. And then, talk to her about, the fact that she's using milk thistle, it's inconsistent with established standards of care with some mixed evidence, but talk to her about, how long have you been on that? Is there any way that, that could be contributing to your elevated liver enzymes and kind of open up the conversation that way. So alcohol and hypertension, here's, we talked about this in that steatotic liver diagram earlier with that kind of flow chart. And I said I was going to kind of get back to it. So let's talk about how isolated hypertension or isolated hypertriglyceridemia can be a tip-off that someone is drinking alcohol. So alcohol has this biphasic effect on blood pressure. And what's really interesting here is how long it causes an effect on blood pressure. I know when I was reminding myself about this data, it's like really surprising about how long it can do that. So you can imagine if someone's drinking every day, like our patient here, right? She's having 2 glasses of wine almost every night. This is very prolonged, protracted elevations of your blood pressure. So she's already on an antihypertensive, but with some weight loss and reduction or complete avoidance of alcohol use, she might have a pretty significant decline in her blood pressure. She might be able to come off blood pressure medications. That can be a motivation for a lot of patients. A lot of these patients don't want to be on a lot of medications, so that can be really motivating. So, and now let's talk about, what the role of triglycerides. So alcohol really sharply increases our triglyceride levels. In this study, it peaked at 5.5 millimoles per liter and remained elevated, with ethanol boosting triglycerides up to 150 to 160% of baseline and persisting for a really significant amount of time. So, 10 hours, which again is just kind of mind-boggling how long it's causing an effect. And if that's something that you're drinking every day, you can see why patients are going to have issues with their triglycerides, and they might be able to come off medication if they're able to address their alcohol use. So, back to our case, so many things we've talked about here about how we can improve her care. Could we start her on metformin? I don't see any reason why we couldn't. Again, don't dump too much on other people when we might be able to make the change. Have the conversation. You can certainly send a note to the primary, but I'd consider putting her on metformin for her diabetes, talking about all the other lifestyle changes. What can we do to make things better? And let's dive into what we can do about her alcohol use. So that's her diagnosis. I think that all makes us sound so intelligent on our notes, but also it really encapsulates the situation here. Can you imagine if you just wrote MASLD? That really doesn't encapsulate all the things that are going on here, and it really, really it helps our colleagues also in the community to also be a part of this process of how we can make things better for patients when we get the diagnosis accurately fitting the clinical situation. So, what are her current treatments? What could we do differently? I kind of talked a little bit, I personally would put her on metformin, definitely talk about diet, exercise, weight loss. Is she a candidate for Resmetirom, which is our thyroid hormone receptor B drug that helps with hepatic steatosis? Certainly seems reasonable in this scenario. She definitely meets criteria with F3 fibrosis without cirrhosis, cannot be on that medication when you have cirrhosis, which she does not. The recommendations regarding alcohol use, I would probably do better than this. Stopping, great. I think, that's one way to have that conversation. I don't know how many of you are having success getting patients to make changes, behavioral changes, by telling them to just stop doing something. I think, a better way of having the conversation is like, hey, tell me what is contributing to this. Most patients who are drinking at an excessive rate, in my experience, are doing it usually for a reason. There's been trauma, there is insomnia, there's pain, there's depression, there's anxiety. So addressing those things is really important. If I have a patient who's telling me I drink because I can't sleep at night, it's like, okay, what can I do to help you to be able to sleep at night? Could we put you on a medication that could both help with alcohol cravings and address your alcohol use disorder and also help you to sleep? Is there a medication that we can help you to be on that is going to help your back pain? Is there something we can do to help with your, PTSD and your trauma that, helps you to also be able to come off of alcohol? I think those are super important. I think we should be doing that in our GI practice. I would absolutely talk with this patient around medication-assisted therapy for her alcohol use. People might think, Oh, that seems really aggressive. Well, she almost has cirrhosis. Is it aggressive? I mean, we don't want her to get cirrhosis, right? So we know there's medications available that help patients with their alcohol use, and I wouldn't hesitate to have the conversation, start those medications. There's not very many. They're usually very affordable. They're easy to take. Naltrexone is an example. It's a daily pill. There's even a injection available called Vivitrol that lasts 30 days. So I would encourage you and challenge you is do better than just telling someone to stop, because I think it will feel much more rewarding to take care of this patient population when you see that they do get better and you can help them and you can make so many changes to their liver disease. And then like we talked about, early on when we got that fibrosis score is, does she need HCC screening? Yes, she does, every 6 months. So she had that ultrasound, depending on when that was done, is going to need another one in 6 months, along with an AFP. So important to talk to patients about that. Again, the more ways you can motivate them, right? I mean, telling patients that they're at risk to get liver cancer, there's going to be patients who are going to be really motivated by that. Maybe it's the piece around not progressing to cirrhosis. Maybe it's the finally addressing the reasons for the alcohol use. I mean, the more things you do, the more likely they are to make the changes. So, how do we need to define MetALD for clinical trials? So, I think we've talked a lot about this, so I won't kind of, beat it down. But the main thing is use objective biomarkers, and we want clinical trials, to start using these things because we know that alcohol use can be underreported. And I think that we have this idea that people underreport because they lie. And think about what it's like for patients, though, in the ways that we react. We're such a judgmental, healthcare can be such a judgmental, dismissive place. For so many people. And so, we just need to be using objective biomarkers and also thinking about the language that we use and what we use with those biomarkers. And clinical trials can be a good way to kind of standardize that. So ensure that, you're evaluating them for cardiometabolic risk factors, that you're looking at their blood pressure and their hypertriglyceridemia after they stop drinking alcohol, and consider their exposure to other risk factors. So what's been going on over the last 6 to 12 months. So let's talk about the take-home messages. So remember about the definitions. Remember that algorithm we had where we have MASH and MASLD, and we have that Venn diagram in the middle, and then we have alcohol-associated liver disease. And when do we start tipping into one side or the other? Knowing that there's so much in the middle where you can have patients who maybe don't have an excessive alcohol use, but are certainly have alcohol use that's contributing negatively. So get comfortable with those definitions and having those conversations. And then use biomarkers. I think if you've probably taken anything away from this conversation, it's if you're not doing them, please do it. Use it as a screening test. Use it as much as you can. And then make sure you're kind of reassessing this patient population, especially when you're making changes that we know from the literature can reverse their disease back. And even in patients who don't reverse, getting a patient to stop in time is a really powerful thing. So not allowing them to progress to cirrhosis is so powerful. I mean, amazing. I mean, that would be a huge achievement, right? I would be very proud. I'd be very excited for that patient. So don't always look at it as that. And then also remembering that, especially patients with all these metabolic risk factors are really high risk to have, their top two causes of death are cardiovascular disease and extrahepatic malignancy. So let's not forget that these are the things that are killing our patients. So we want to see those get better. Like when I see this patient back, I'm hoping that her A1C has gone down because I started metformin. I want to see her back in 3 to 6 months. I want to see that A1C go down. That's a huge win for me. It's a huge win for her. It's a win for her liver disease. It's a win for her overall health. So make sure you're reassessing those things and motivating. Like that can be so great. Like what a win. Like maybe we didn't accomplish all of our goals, but anything that we're doing to move the ball forward is a positive thing, and can be really encouraging to patients to keep doing the things that they're doing, especially the lifestyle things, which are very hard for all of us, right? And then, think about the fact of had they had adequate exposure to those risk factors. So if a patient has only been binge drinking for the last, month, how much of that is driving their liver disease? So kind of talking to them about like how things have changed, because certainly these things can evolve and change. Sometimes people have gained more weight. just very recently. It might be for a variety of reasons. So important to take that in mind as well. And then, clinical research really trying to think about like, how do we make these more objective diagnoses and then really being culturally competent as well and about how these things affect, different sociocultural realities for the patients that we're taking care of because we know that makes a huge impact, similar to what I said about the rates of alcohol use being much higher in my practice, right? 15% is not what I'm seeing. So thinking about how these, why am I seeing higher rates of that, and what does that have to do with the specific community that I'm living in, and what that looks like in the realities for my patients. So that's the end of this talk. I thank you all for joining. I'm going to pass it over to Gail, who's going to give you a couple more tidbits for the end. But thank you so much, and it was my pleasure to do this. If you have any questions, please let me know.